I'm gonna let. My name is Sarah Dugan. I'm a mental health pharmacist and faculty here at Neomed. And as Crystal had mentioned, our topic for today is antipsychotic polypharmacy. My objectives for this brief presentation are to define polypharmacy. So what is it that we mean when we use that term? Talk about the rationale for use. So why is it that this is something that's occurring? And are there issues with it? So we're going to try to identify some of those concerns, and we'll briefly take a peek at some of the literature related to antipsychotic polypharmacy. Starting with definitions, I like to make sure everybody's on the same page. So polypharmacy, the official definition is the use of two or more drugs together, usually to treat a single condition or disease. So if we're using two medications for one diagnosis, that's where kind of the threshold would be for polypharmacy. That's also the threshold we're going to use for today. It could potentially be an antipsychotic that's used with mood stabilizers, things like Depakote, with anxiety medications, so some of our antidepressants like Prozac or fluoxetine, hypnotic, so some of the sleep medications that patients take, or even combinations of antipsychotics. My focus for today is going to be on just the combination use of antipsychotics. It's a little bit too big of a topic for us to tackle them all in the course of just 10 to 15 to 20 minutes. One thing I did want to point out is there's a bit of a shift. While the definition of polypharmacy of two or more medications together really has been the one that's been traditionally used, there's a bit of a shift to look more broadly. So not just at the one diagnosis, but at patients who are taking 5 or more medications at a time. Now, this could be for multiple different diagnoses. It also could potentially be a patient who has one diagnosis and is on maybe 1 or 2 medicines for that, but then uses multiple other medications for side effects. So to manage that. So they've really started to diversify this to try to minimize the adverse effects patients are experiencing. One of the reasons this has come into play is because not so much for our first episode folks, but for the folks that are at the end of the spectrum, for older patients, we recognize that there are a lot of adverse effects. They could have been on a medicine for several years, if not decades, with no problems. And then as they age, things shift, things change within the body, and they may start experiencing adverse effects. So they're looking not only at the number we use for one diagnosis, but overall pill burden. I'm going to talk about that just briefly, but really the focus is just going to be on the use of 2 or more antipsychotics. So first, to start with, I wanted to look at where in our treatment guidelines is polypharmacy even mentioned. In the United States, one of our main treatment guidelines for the treatment of schizophrenia is the American Psychiatric Association, so the APA. In the APA's updated guidelines that were released in 2020, the pharmacotherapy section does not talk about the use of polypharmacy. There are some sections that have text that talk about specifically for first episode. They want to use the lowest dose of medication possible to control the symptoms. So it really seems to be shifting not in the direction of polypharmacy. Our neighbors to the north in Canada have their own treatment guidelines. In their treatment guidelines, they do not recommend the use of combination antipsychotics, so polypharmacy, but there is a mention. So in recommendation 3, under patients who are non-responsive or clozapine resistant, it's listed as a treatment option. It's there with a couple other treatment options that this could be done, but it's not well supported at this time in the literature. So they're also not promoting it. If we look across the pond in the UK, they have the National Institute for Health and Care Excellence, and their treatment guidelines also have a mention of the use of augmentation, so antipsychotic polypharmacy, but only for those patients who were non-responsive. Their specific terminology is if they didn't respond to treatment, if you ruled out any other reason why the patients didn't respond to the other antipsychotics, and you got a clozapine level, then you could add something to clozapine for about 8 to 10 weeks. So it was very small in where it was identified. And again, real recognition that early in the course of therapy, we're not looking to use combination. We want to expose patients to as minimal amount of antipsychotic as possible. So why is this a big deal? If the treatment guidelines are saying that we shouldn't be doing this, then is it actually being done? The answer is yes. Not only is it being done, but it seems to be being done at an increased rate, especially here in the US. There was a systematic review that was conducted and published in 2020. They looked at several studies that provided information from across the globe, and they found that the median, so the middle prevalence of antipsychotic polypharmacy, so if we're looking at about an average, was just under 20%. So of patients who have schizophrenia, about 20% of them were being prescribed more than one antipsychotic. There are other studies that would suggest that number is closer to 30%. There was a bit of a delay in them getting the data, so it is possible that that number is even higher than what it is currently. There was a smaller regional trial that was done in the United States to see is there a difference in what our states are doing, and they found that yes, there is a regional difference. States such as New York and Pennsylvania had higher rates of polypharmacy than states such as California and Texas. So depending on where you're practicing, there may or may not be a tendency to be using multiple antipsychotics. But this is changing over time, and in general, at least for us in the US, it is increasing. So this was that systematic review. Interestingly, in Asia, in the 1980s, about 50%, over 50% were reporting antipsychotic polypharmacy. Well, us in North America, so that did include Canada and Mexico, there was more data available for Canada than for Mexico, so they were a little bit more represented. It was about 12.7%, and it's increased up to 17%. And again, now some of those estimates are between 20 and 30%. So we are seeing a steady rise in the number of patients that are being prescribed more than one antipsychotic. So it wasn't in the treatment guidelines, but it's definitely happening. So why is that occurring? They've identified a number of different rationale for the use of multiple antipsychotics. In some cases, they're trying to use lower doses of some antipsychotics in combination with other antipsychotics to take care of side effects. I think one of the common combinations that's being utilized, I almost said promoted, but I was able to stop that. So it's not necessarily being promoted, but one that's being utilized is clozapine and aripiprazole. So they're adding the aripiprazole on board, thinking that it's going to assist with reducing some of the weight gain that patients experience with clozapine. In some cases, it can bring the weight down. From a prevention side, it's really difficult to be able to prove that it can prevent weight gain because you can't prove that the patient's going to gain weight anyways. So that makes it a little bit tricky. Patients who have too many side effects, if they haven't responded to other antipsychotics, they were put on clozapine and they don't respond very well. Those that are doing cross titration, so if they were trying to get off of one medication as we're increasing the dose of another, sometimes they get stuck right in the middle. So during that cross titration, sometimes we see combination therapy. Economic concern I thought was interesting because this would be 2 medications, which would suggest that there would be 2 copays. There may be 2 different monitoring parameters that are required. So yes, there can be economic concern, but I guess I'm a little confused on how that would be a benefit if we're using more than one medication, but it's been listed as a justification for why they're doing so. Maybe they're using 2 cheaper agents as opposed to going to a more expensive one. That maybe that's where that came from. Rapid therapeutic response. So as I was talking about that cross titration, if a patient gets started on a new antipsychotic as we're trying to get rid of the old one and things resolve, so symptoms improve, oftentimes it's like, okay, let things be hands off. Like, let's just hold steady right here because we want to maintain that benefit. So sometimes that's the reason why individuals get stuck on more than one antipsychotic. If the course of their illness, they have very severe symptoms, the prescribers may believe that they have evidence, whether it's been done in-house, things that they've seen anecdotally, some of the studies that they've come across, although it's limited and very inconsistent, or they just may be skeptical about what the treatment guidelines say. So yeah, that is a document, but not necessarily the way that they feel that they need to practice for their patients. The last two reasons why some of the folks are prescribing more than one antipsychotic are to treat additional comorbidities. So if there's something else that they believe one of the antipsychotics may be more beneficial for, and unsatisfactory efficacy. So there's just these residual symptoms they haven't been able to get rid of. So no judgment on the rationale, but that's a handful of reasons why this is being done despite not being identified in the treatment guidelines. Now let's look at the flip side. So what might be some of the drawbacks? What are the concerns? Why is this, if there are all of those reasons, why is this not being more widespread? In some cases, if we have more medications, that means a more complicated medication regimen. That may be difficult for the patients to be able to adhere to. So maybe if I only have to take one medication at bedtime, but now I have to take two, and one is twice a day, and I have to eat with it, it can get more complicated and reduce the likelihood that they take it the way that they're supposed to. Decreased quality of life. So there have been some reports that the use of multiple antipsychotics or higher dose antipsychotics can reduce some of the functionality and satisfaction with quality of life in some patients. There's a concern that there's an increased risk for adverse effects. So if this medication has this many adverse effects and we're using another medication that has this many, now that's going to be additive, if not even more, to really compound some of those adverse effects, those unintended consequences patients are experiencing. More meds means it increases the risk for medication errors. We don't have a ton of data to support the use to say, absolutely, this is better. Hands down, a combination would be better. And there's some, I put in asterisks here to remind myself, there is some evidence to suggest that patients who are on more than one antipsychotic have an increased mortality rate. That evidence is inconsistent. There are some reports that say it goes in the other direction. There's also reports that suggest that because patients are really severe and maybe uncontrolled, that it's the patient population that ends up on a combination that has a higher mortality rate. So that one's a little bit gray, or not quite as definitive in terms of risk. But all of those would be concerns for having folks on more medication. So what do we have in terms of evidence? Can we prove that this would be something that would be better? In general, across the board, it is not recommended for first episode patients. They recommend using one medication, lowest doses possible, because we know that those first episode patients tend to experience adverse effects a little bit more than folks who have had schizophrenia for a longer period of time. So I wasn't able to find information in just that population, so I looked a little bit more broadly. There are a few studies that do look at this. I selected two of them. So this one, and then one that's a meta-analysis that looks at a couple different outcomes. But I picked this one for sake of time to make sure I stay on time, but also because it was the largest population I could find. So this was an observational study that was done in Finland. They were able to follow the data for over 62,000 patients who had had schizophrenia. So they identified patients within their national database who had a diagnosis of schizophrenia and had been hospitalized from as far back as 1972. They followed them starting on January 1st of 1996 all the way through December 31st of 2015. And they were looking at how many of those patients ended up being hospitalized during that time frame. Those were all of the patients that had been identified in that bigger cohort. That was the prevalent group. The incident group were folks who newly got diagnosed with schizophrenia. So those that got discharged from the hospital with a psychiatric diagnosis of schizophrenia and ended up with a prescription for antipsychotic medication. So those were really the newer cases that popped up since January 1st of 96. The main thing they were looking at is outcome. So the main outcome they were looking at is rehospitalization. So they wanted to know if the use of one antipsychotic or more than one antipsychotic can keep patients out of the hospital, both for mental health reasons and then for any cause being in the hospital. So what they found was that, my numbers didn't come through on those two. It was about the same, the number of rehospitalizations over this period of time in both the folks who had a diagnosis of schizophrenia as well as those who were newly diagnosed of schizophrenia. It was just under 60% for both groups. For all-cause hospitalization, for those who had an existing condition, an existing diagnosis of schizophrenia, about 86% of them had been diagnosed had been hospitalized for any reason, so medical reasons as well as those mental health reasons. So that additional 30+% was more for those medical reasons. For those that were more newly diagnosed, it was about 80%. So again, no difference between the two groups, but most of those patients did have to be hospitalized over that time frame. When they looked at the number of patients who were using polypharmacy, so we're on more than one antipsychotic, it was more than 50% for both populations. So it was just short of 70% for those who had historically had a diagnosis of schizophrenia, and it was about 54% for those who were more recently diagnosed with schizophrenia. Now that's the group that is a little bit more applicable to this group. So those would be a bunch of the first episode or more newly diagnosed patients. So we still were seeing antipsychotic polypharmacy in about half of them. I said the incidence before was between 20 and 30%. So at least in this cohort, it was even higher than that. So what were the differences? What did that look like? They found that one of the biggest benefits for the use of combination therapy actually was with clozapine and aripiprazole. So what they did, and I just want to orient you to this, so it was clozapine monotherapy, and then they compared every combination to just the use of clozapine. Then they went to aripiprazole. So what did aripiprazole monotherapy look like? And they compared all of the combinations to aripiprazole. So that's why you'll see slightly different results for these two findings. So clozapine and aripiprazole is this first dot under clozapine as well as under aripiprazole. Our hazard ratio is how likely are they to get hospitalized. So if the little dot falls on the right-hand side, it's less likely they're going to get hospitalized if they use only one medication, so monotherapy. If it falls on the left-hand side, that means that they're less likely to be hospitalized if they're using the combination. And the biggest results they had was that clozapine aripiprazole combination. So it reduced the number of patients who required hospitalization. There wasn't much difference for the rest of the combinations of clozapine. So with olanzapine, any long-acting, risperidone, or quetiapine, or even some of our older first-generation agents. Same with aripiprazole, no difference. So if it hits this line, this one line, gray line that goes all the way down, there's no difference between the two groups. When we get to olanzapine, there was a benefit when it was used with long-acting injections, so any long-acting injection, as well as when it was used with clozapine. For risperidone, there was a benefit when it was used with clozapine, and quetiapine had a big benefit when it was combined with other medications. I find this interesting. They did not give me dosing information. In general, we don't necessarily see quetiapine or Seroquel being less effective, but it really had lower hospitalization rates when it was combined with something else, which makes me wonder if the quetiapine, the Seroquel, was added on board at a low dose for the use of something else, insomnia, anxiety. So I'm not sure that that really was the driver for treatment of if the quetiapine was the main medication being used in the treatment of schizophrenia, I kind of think that might have been one of those comorbid situations. But they didn't give us that information, so that's just my postulation. So in looking at this data, there were some combinations that seemed more effective, at least in reducing hospitalizations. What it did not tell us information about whether or not they stayed on it. So were there more people who dropped out because of side effects on the combination groups? Are there people who were doing much better? Were these folks just doing way worse? So we don't have some of that information, but it does look like maybe there's a reason why we'd want to use the combination. So I wanted to pull one more study. I recognize I'm almost at time, so I am finishing up. So this was a systematic review. It pulled in 5 other trials, and it specifically compared patients who were on more than one antipsychotic. Some of them were on up to 5 antipsychotics at a time, which is a little excessive. And they compared whether or not they stayed on the combination versus tapering off and ending up only on one medication. They looked at a couple different outcomes. They looked at patients' quality of life as reported by the patient, rehospitalizations, which we just looked at, and then adverse effects. So were there more adverse effects? What they found, there was no difference if they stayed on the combination or if they discontinued and only ended up on one antipsychotic. So their symptoms were consistent. They didn't need to be in the hospital, but interestingly, they didn't see a difference in adverse effects. Now, it was a huge range that they gave us, so possibly there are some adverse effects like movement disorders that there were less of, but there were still other side effects that maintained. So what does this mean putting it together? It means that even though the polypharmacy isn't recognized in our treatment guidelines, it's being used. It's being used robustly. Is it a benefit? It looks like in some patients it might be a benefit. Could it be a problem in other patients? Possibly. We don't have a lot of information to be able to prove that we get more side effects if we're using more medications. So it would be very helpful to continue to evaluate this in broader and broader populations outside of just the Finland group. So with that, I am finished. I will turn it back over to you, Crystal.